Hello everyone, we are going into the second lecture here about pediatric physical therapy. This is chapter 12 in your book. Reason why we talk about pediatrics, we talk about the whole scale and we talked about the developmental milestones first, so we can kind of go into this portion of it. It is our job to determine if the stage of what these children are at is where they should be, and our ability to meet those tasks related to the challenges on a daily basis. So we want to make sure that children are meeting these developmental milestones when they should be, and that they're doing it mostly in order, and that's why it's important why we had the other lecture first. Children, we have to think about children aren't a scaled down version of an adult. They have milestones to progress through, and they have to meet them, and we need to make sure that we are focusing our efforts on that. Differentiating between normal delays and developmental problems is our job. We have to have the knowledge of what they're doing in that developmental stage to be sure that we say, yes, that is a problem, or no, that's not a problem. Is not walking because he's stubborn, or is there an issue that's actually happening? Walking is approximately 10 to 13 months. Some take as early as 8 or as late as 18 months. So we need to know where that problem actually lying. And remember that children play first. Therapy looks very different in a pediatric setting. It is most appropriate for young children, and those activities need to be age specific, gender specific, culturally specific, and in their natural environment or physical environments. So when thinking about age specific playing and gender specific playing, making sure that these what you're giving your patient is something that they want to do. So I know that there's a lot of news going around about gender neutral and being the same towards each one. And really what I mean by gender here is just making sure that you're going with what that child actually wants to do. Children with special needs, or what they say now is children with special health care needs, they require special care and really a team of professionals. That's why they call it family-centered, because it's not just the therapist and the patient. The family really has to be involved in it well. And we want to include anything with prevention, early identification, evals, diagnosis, treatments, and rehabilitation. And we recognize it as a whole system for the child, not just one person. The classification of disablement, the process of disablement is finding that impairment, functional limitations, and disabilities. The process of enablement is improving structural and functional integrities, activities, and participation. But these don't just affect their health, it affects their activities and participation as well. We're not just looking at this disablement factor. We're not just looking at the disability. We're looking at the whole picture, and that's what is the problem in their activities and participation as well. So the impact of federal legislation, the pediatric PT constantly is evolving due to public policy, family-centered care, and environments for practice. So you'll find that the EHCA, or the Education of All Handicapped Children, was enacted in 1975. That was reauthorized in 1991 as the IDEA, which is Individuals with Disabilities Education Act. It started as just children 6 to 21 were entitled to free and appropriate education, and then it made a distinction for birth to 3 years and 3 to 5 years. So it's including all of the children and not just children at 6. So developmental delays is really the focus of the pediatric PT. Children without a developmental delay are usually seen in an outpatient ortho clinic, but usually that pediatric PT is where the developmental delays are happening. It's a failure to attain predictable movement patterns or behavior associated with children of a similar chronological age. So they are behind in what they're doing. you'll see with Down syndrome or some conditions, which we'll go over, play a role in all of these. So this is a milestone of motor development slide. We have already gone over the motor developments in the previous lecture, so I'm not going to even touch base on this. Just know that it's previously before. So these are the common conditions that we're going to go over today. We'll go through each one and kind of give a brief description on what they are. So JRA, juvenile rheumatoid arthritis, is an inflammation of a joint. The cause is unknown. It's not just in the joint as well, it's in the joint and the connective tissue. It appears to have some genetic environmental factors, but really we don't know why it happens. The symptoms are joint pain, swelling, decreased motion, stiffness, and muscle atrophy. The treatment really is medications, therapeutic exercise, and specialized care. And really we want to prevent any deformities and make sure that they have a good quality of life. Physical conditioning has been shown to help without increased symptoms. And the family should be included in all of the goals for everyone, not just them, for all of the conditions we're going to go over. Clubfoot is affected foot is turned inward and slanted upward. This foot becomes fixed and muscles shorten. Really, they shorten and the joint can't go back to its normal position because it has shortened. Usually you'll see the treatment as casting, splinting, taping. There's sometimes a manual correction after birth. Sometimes if it's really, really bad, then they'll go surgical. Really, the cause, again, is unknown, but the position in utero could also result from a brain injury. I'm sorry, I said that all in one sentence. The position in utero is really what I believe is the main factor of it, but there could be a brain injury that affects a nerve and sort of that bone system, which can cause it as well. Scoliosis, if you remember from when you were in elementary school, when they'd have you touch your toes and the nurse would run their hand down their back, that's what they were testing for, is that scoliosis. Again, the causes is unknown. They're not sure exactly what could be the issue. It could range from a mild to a severe. This is a severe case that we're looking at here. The treatment is an internal or external fixation, so they could do just a brace on the outside or do actual surgery to fix it. There's heard of some electrical stim, but I also heard that there's had no effect on actually preventing it. It's just helping it a little bit, make it feel better. You really want to exercise and reduce the pain and increase range of motion, and then work on positioning to reduce pain and increase mobility. So that way you're teaching your patient really how to posture themselves correctly and strengthening the body in the way where it will hold the position better. Developmental dysplasia of the hip. Right here you'll see a newborn with that condition. He's actually braced so it will grow to a position that's appropriate. This is abnormal development in which the femoral head can slip in and out of the acetabulum. This, you'll see the baby is just held in a position that will not happen. The factors that can go into this are maternal hormonal changes, birth trauma, or improper positioning after birth. The treatment usually is manual or surgical repositioning, stabilizing with splints, which is what you see here, and intensive exercise protocols. This happens more likely in children with spina bifida or CP. Osteogenesis imperfecta, or OI, is brittle bone disease. There are frequent fractures in this. Side note, that's a cute little chubby arm that we're looking at. There are a lot of fractures. There is a high mortality rate in the fetal form. The infantile form is a little less severe. Symptoms are limb deformities, dental deformities, stunted growth, scoliosis, loose ligaments, and unusually shaped skull, mostly because of the fractures that were happening. The treatment is really fixing those fractures and preventing any deformities. They can do some gentle range of motion or gentle exercise, but it's typically preventing of any more fractures to happen. Duchenne muscular dystrophy. The females are carriers, but the males manifest the symptoms. So this does not happen in females, but we just carry it on to the next person. Typically, they develop normally until about 3 to 5 years, and then they develop progressive lower extremity weakness and wasting. So you'll start to see the muscle going away, and they're not able to use their lower extremities. This is also seen in enlarged calf muscles, but they are very weak, and tight heel cords, and that heel cord is where the Achilles is coming down. Complications is muscle contractures, spinal curvature, and they will be in a wheelchair dependent at 10 to 12 years. They will no longer be able to walk because of the weakness. This also continues throughout the whole body and moves up. It has pneumonia and cardiac abnormalities, eventually leading to an early death. I have read that nighttime ventilation can help increase the lifespan as much as 25 years. So it is unfortunate. It does get to an unfortunate ending. Spinal muscular atrophy, or SMA. This has severe weakness in infancy and progressive respiratory failure. There are several types, and it depends on the severity and onset, but affects the part of the nervous system that controls voluntary muscular movement, and that muscle doesn't receive the signal, which makes the muscle inactive. The infantile form, again, is a decreased lifespan. The juvenile form, if it comes on a little later, you can live a little bit longer, but it is still less than a normal life. So spina bifida, the cause, again, is unclear, but they believe that there is some genetic factors going into that. It is a faulty closure of the neural groove in the first month of pregnancy. There are different forms of it. An oculatiform is not associated with any disability. Nothing really is wrong. Meningocele, which is a benign herniation of meninges manifesting as soft tissue cyst or lump. It doesn't actually break the skin. The meningomyocele is an open lesion with little or no skin covering the deeper nerve roots, often seen as loss of motor function, sensation of the lower body. So this is where it's actually coming out of the skin and it is open. They would be able to see it, and that is the most severe type. Sometimes it has a fluid leak, but this is including a bowel and bladder dysfunction. Cystic fibrosis, there is no cure for this. There is a pulmonary disorder, most commonly inherited in white children. The production of thick mucus with a progressive lung damage, and the child require frequent hospitalizations for acute respiratory attacks. Sometimes lung transplants, but the life expectancy for this is 40 years, and that's actually increased 2 years in the past few years. Down syndrome, which is an extra chromosome 21. There is low muscle tone, a flat face, upwardly slanted eyes, short stature, slowed growth and development, and congenital heart. There are varying levels of intellectual disability. There is decreased muscle tone, decreased balance and stability, and there are a few complications including lax ligaments, seizures, leukemia, and premature aging in some. Because of that low muscle tone, decreased balance and stability, that gives us as therapists a lot to work on. Cerebral palsy, which is a group of conditions, it's not really a disease, but that occurs by a non-progressive lesion of the brain during gestation or at birth. It's really a lack of oxygen that's happening, and then it gives it an inability of the brain to control nerve and muscle activities. Some of the early signs that you're going to know about it is poor sucking, irritability, hypertonia, hypotonia, and reduced movement. And some later signs that you see are delayed motor milestones, poor coordination, and involuntary movements. Fetal alcohol syndrome is one of the ones that is 100% preventable. You just don't drink when you're pregnant. And this is by just women drinking and not going to the baby. It is the leading known cause of an intellectual disability. Children born at term but are smaller in weight and height. They have increased heart defects, joint contractures, auditory impairments, and hip dislocations. There's a wide range of language delays, fine motor control, eye-hand coordination, speech, and typically a lower IQ. Some of the physical features you'll see in these pictures here is widely spaced eyes, a short upturned nose, a thin upper lip, a flattened groove in the midline of the lip, and large low ears. Prenatal cocaine exposure, which I have also looked up opioids, and it's sort of the same. Hyperirritability, poor feeding patterns, high respiratory heart rates. Really, the reason why they're having this is because they are going through withdrawal. They'll have the shaking, the quivering, irregular sleeping patterns because they're going through a withdrawal of a drug because of the mother taking the drug while pregnant. Abnormal muscle tone or tremors, and newborns will go through that withdrawal system. So if we think about the examination of children and how we're going to treat them, we determine if the child needs PT and then measure progress once that PT has begun. Again, it's the same. This history, system review, screening, test and measures, we're doing all the same ideas. There is certain standardized testing with children. There's an ages and stages test, a Bailey scales of infant development. These are formal tests in which procedures remain the same when administered by different therapists and at different test locations. So we are looking to see, are they doing the same things with different people and at different locations? And then we take that normal reference by a large group. So we test a huge group of normal children on these scales, and then we can take our children with disabilities and see where they fall on that. We record the SOAP note is rarely used in pediatric population. It's really only used in private practices. Instead, we use an IFSP, which is Individualized Family Service Plan, or an IEP, Individualized Education Plan. The IFSP is used in early intervention, that birth to 3 years, and the IEP is used for the school-age children, 5 and up. The book talks about the knowledge base for pediatric. The PTs find it useful to be detailed in these items to be a good pediatric therapist. Direct intervention. Your treatment is going to look more eclectic or a multiple method approach to treatment. It never stays the same because children don't want the same thing. So when you're treating a child, they're going to want their treatment to be different. With an adult, you can do straight leg raises, quad sets, heel raises every single time they come in. But for children, they're going to get bored and they're not going to want to do the same thing. So that's where this eclectic, varying ideas and styles really comes from. And they're going to require management for acute and long-term orthopedic conditions, so it's going to need to change all of the time. There are some different approach theories. I'm not going to go into these. I just want you to sort of read up on them in my slide and on the book, both the neurodevelopmental treatment approach, the sensory integration theory, and the task-oriented model. And we'll go over them in class. All right. Thanks, guys. We'll talk in the next few days.